All right. I think I'm hitting all the buttons correctly here. Welcome to today's live webinar, Broadening the Spectrum of Care, Early Cancer Detection Technology for Lumps and Bumps, sponsored by HT Vista. We're so glad you're here with us today, and also want to extend a warm welcome to our YouTube audience who is joining us, I think, for the first time today. Welcome, everyone. I'm Dr. Cassie. I'll be your host and moderator. A few housekeeping items before we begin. This session is being recorded. It will be available later this week as an on-demand course on Vetfolio. And if you registered on Vetfolio and you're attending live, no further action will be needed for your CE credit. If you registered on YouTube, be sure to fill out the JOT form that's linked in the description, and you'll see your CE certificate in your Vetfolio learner profile within 24 hours. And with that, I'd like to go ahead and welcome our speaker. I'm so excited to have Dr. Kate Boatwright with us today. Dr. Boatwright has been in small animal practice since graduating from the University of Pennsylvania in 2013. And after nearly 8 years of full-time practice in both general practice and emergency clinics, she moved to part-time clinical work in order to pursue her passion for educating veterinary professionals as a freelance speaker and author. Dr. Boatwright very much enjoys discussing mentorship and spectrum of care. And in her remaining free time, she stays busy chasing her toddler, running, reading, and watching movies with her husband and her cat. That sounds wonderful. Dr. Boatwright, I'll go ahead and hand it over to you. Let's get started.
Hello, everybody. It is so great to be here with you today. I'm very excited to be here and talking to you about combining one of my passions, which is spectrum of care, with a really great new technology that is really changing the way that we can approach lumps and bumps in our canine patients. And it is offering us new ways to approach these cases and letting us overcome some of the barriers that have historically prevented us from making some of the diagnoses that are really important in clinical practice. So I want to start by kind of reviewing what spectrum of care is. And it is not a new way to practice medicine. It's just a new term for what a lot of people have been doing for many, many years. And it encourages us that instead of thinking about medicine as an all or nothing for each of our cases, that we think of it as a range. And on one end, we have our traditional textbook approach. This is going to be what we think of as our gold standard or best practice. And then for a given condition, we may have palliative care or symptomatic treatment. Sometimes it's just benign neglect. Sometimes it's euthanasia. It depends on the condition. But in reality, there's a huge range of options in between. And the majority of our patients are going to fall in that middle ground. And it is our job as veterinarians to work with our clients and find the option that fits their needs the best. And when we think about spectrum of care, we have goals. For our patient, it is to maximize their quality of life. For our client, it is to remain responsive to their individual context. And while we oftentimes come at spectrum of care from the financial angle, and we think about offering different options at different price points, there are a lot of other options and things that we need to think about as well. We may have a client who has some physical limitations and isn't able to provide the nursing care that their pet needs. Or perhaps they have dexterity issues and they can't administer insulin injections. Maybe they have a crazy work schedule, and so coming in for frequent visits to the vet clinic or administering medications on a rigid schedule is going to be difficult for them. Or perhaps they have another pet at home or a family member that they are giving a lot of care to, and so they don't have a lot of emotional or mental bandwidth to add in more care for another pet. And so we have to put all of this together when we think about our cases. I had a client a few years ago who came in and they had an older dog and he had a big tumor on his toe. And we had the conversation of, I was concerned that this was a malignancy. We talked about what the workup would look like. We talked about what treatment would look like with surgery. And the owner asked if euthanasia would be a reasonable option. And I was originally a little taken aback by that question because it wasn't something that I would usually jump to for a tumor on a toe. But as I talked to the client more, I found out that his wife had stage 4 cancer and she was on hospice at home. And so there were concerns about his ability to care for the pet after surgery. He also was concerned because this tumor was infected and oozing. And so there were sanitary concerns about this pet being around the immunosuppressed spouse. And so we ended up finding another solution for that patient and client, but that was where that question was coming from. And had I reacted with just a gut reaction of, oh, how dare you think about euthanizing this pet with a fixable condition, that would have really alienated the client. And so that's why when we think about spectrum of care, we really have to come from a place of curiosity. And by doing this, we as veterinary professionals are able to meet our moral, legal, and ethical obligations. And in fact, in the most recent update to the Principles of Veterinary Medical Ethics back in 2024, the AVMA did add in contextual care, which is a synonym for spectrum of care, into our ethical duties as veterinary practitioners. When we do this, it really is about assessing the patient, going back to the basics, our history, our signalment, our physical exam, combining that with the evidence that we have available to us, talking to the clients about what barriers may be at play, and putting that all together to develop that range of diagnostic and treatment options that is potentially a good fit for the case. And then we present those options to the client. We talk to them about the risks and benefits of each option. We talked to them about the prognosis and possible outcomes, and we talked about the costs. That's the financial costs, but also the physical and emotional costs that may come with each of those outcomes. We have to do it in a way that the client understands. And ultimately, once the client agrees to a plan and we engage in that decision-making process together, we have obtained informed consent from them. We document that, and that is how we protect ourselves from liability. Because that's one of the biggest pushbacks I hear from other colleagues when I talk about spectrum of care is if I'm not following the textbook, if I'm not doing by the book medicine, am I opening myself to liability? And the truth is, no, you're not, as long as you are educating the client about the options and helping them to make a decision that they are comfortable with and then documenting that. But it is also important to remember that if circumstances change, if we learn new information about the pet or about the disease process, then we may need to reestablish informed consent and revisit those options. And so that's kind of the basics of how we do spectrum of care medicine. And it may sound familiar, even if you don't know the term spectrum of care, because that really is what we do in veterinary medicine. And now I want to look at how we apply this in specific situations where we have dogs coming to us in the clinic presenting for lumps and bumps. So I don't know about you, but I get really excited when I see an appointment show up on my schedule that says check lump. Because to me, I always look at that as an opportunity for an appointment to turn into a surgery. I love surgery, and I know we've all heard the term a chance to cut is a chance to cure. And it's true, especially for a lot of our dermal and subcutaneous masses, that if we catch them early, we diagnose them, we get them into surgery, we get clear margins, a lot of those surgeries can be curative. The trick is that we have to find these pets as early as possible so that we can make sure that we are getting them to the point where we can do surgery. So if you think about seeing 20 dogs in your waiting room and all of them have a lump on them, statistically speaking, 3 of them are going to have a malignancy. And your job as the veterinarian is to find those 3 dogs. And you want to find them as early as possible. So, how many of you right now are aspirating 100% of the dogs that come in with a lump on examination? I know I'm not, because there are a lot of reasons that that doesn't happen. And when we think about our current spectrum of care, we know that kind of gold standard definitive diagnosis is going to be histopathology. Sometimes we're doing an incisional biopsy, sometimes it's an excisional biopsy, but we're not usually jumping right to that on day 1 of the appointment, because most clients aren't going to go straight to surgery. Additionally, we probably aren't going to be sedating or anesthetizing all of our patients in our short appointment schedule. But depending on the location, that may be part of our workup. Most of the time, we're probably talking about FNA as our main diagnostic tool for these lumps and bumps. And we can review them in-house, or we can send them to a clinical pathologist and have that expert review. And if we don't do that, we're left with wait and see what happens. Maybe we take some measurements, maybe we have a body map that we draw onto, take some photos of the lumps to document them, but we don't know what the lump is if we go that route. And so we risk having dogs walking out of our clinic with cancerous lumps that have gone undiagnosed. And this is data from a survey that HT Vista did with Clinicians Brief earlier this year, and they surveyed general practitioners about their management of cutaneous and subcutaneous nodules. And so, on average, veterinarians in general practice are seeing a little between 2 and 3 masses per day, so 2.7. And if we extrapolate that out to how many days we're working in a week, about 5 days, we're seeing 13.5 masses per week per veterinarian. But only 38% of them are being aspirated. So 8 of those masses are going undiagnosed. Of those that are aspirated, 66% are being read in-house and 39% are being sent out to the lab. And those numbers don't add up to 100% because some masses are starting with an in-house read and then being sent out. So, these are the averages for both individual questions. But ultimately, we have 5 masses that are actually being assessed. 3.5 of them are having that in-house fine needle aspirate performed. 2 of them are being sent out for expert review by a board-certified clinical pathologist. And this works out to overall only 16% of the lumps and bumps on dogs that are walking into our hospitals are being reviewed by a pathologist. And that is a lot of risk that we are missing significant cancers that our patients are walking around with. And we know the longer these go on, the higher the risk to our patients. And when we think about why that number is so low when it comes to aspirate, why is only about 1/3 of our cases being aspirated? I like to kind of break it down into buckets of client, patient, and veterinarian factors. So when we think about the client perception, sometimes it's cost. Sometimes it is concern for causing their pet pain. We describe the fine needle aspirate process, and I'll tell clients it's a small needle that we stick into the lump and get some cells out. And, I'll tell them it's the same size that we use for vaccinations and blood draws. But some clients are still, well, I don't want to do anything extra today. If it's a wellness appointment, we've already done vaccines and we're doing blood work. And I just don't want to put them through that. We'll think about doing it another time. Or sometimes I hear, well, I don't want to know. I wouldn't treat it even if I knew it was cancer. And, these are real fears and reasonings that our clients have that we have to be able to discuss with them and talk to them about why, even if they may not want to do a definitive treatment, knowing what that lump is can still be helpful in how we manage the patient. And then we have some patients who aren't going to cooperate, even if their client, even if their pet owner would really, really like to do an aspirate. And, they see us coming with that needle and they are not going to have it. And so this one is often a little easier to get around. We can do some injectable sedation, or we can do, reschedule with some pre-visit pharmaceuticals on board. But some clients don't return if the patient wasn't cooperative at that first visit. So sometimes our patients create their own barrier. But we have to be realistic that sometimes we get in our own way too, where we make assumptions that the lumps are benign, or maybe we just feel like, I don't have time. I'm pretty sure this is benign. I'm just going to tell the client that and not talk to them about an aspirate. And I think there are some times where veterinarians have different levels of comfort with interpreting an FNA, and we may start to feel guilty about the cost of sending FNAs out to a clinical pathologist. And so we may feel uncomfortable offering that to a client. And going back to that survey, when HT Vista asked veterinarians what is the primary reason that you're not performing aspirates, the number one reason was not cost. The number one reason was veterinarians said, I felt the mass was benign and didn't need investigation. And I'll admit I've sometimes felt that way. And, I say kudos to the vets who answered the survey and were honest about that. But at the same time, we know that that is not a valid reason to not offer an aspirate to a client. We need to make sure that we are offering clients the opportunity to gain a definitive diagnosis, because we cannot diagnose masses by palpation alone. Other reasons that we'll see here are a lot of what we talked about, those time constraints, not being able to do cytology, not being confident in it, and then the other client reasons. But far and away, cost and just our own perceptions are the top two reasons that aspirates aren't happening. And this is Izzy. And she is my reminder of how important it is that we not make assumptions about our masses. Izzy is a lump factory. I have probably removed 30 masses from her in the last 4 years. She forms cysts constantly. And a lot of times, though, eventually one of the cysts will get infected and it'll rupture. And when that becomes a repeated issue, we'll get her set up for surgery. And at that point, a lot of times the owner will ask us to remove numerous other lumps to try to prevent them from becoming problems in the future. So about once a year or so, I'm doing surgery on Izzy and removing numerous lumps. And a couple of years ago, we went to surgery on her, and there was a lipoma that was planned to be removed. Well, it had never been aspirated, and it was just that soft, freely movable subcu mass. It was assumed to be a lipoma, and so it was, yep, sure, we can take that off during surgery. So I'm in surgery and I make my incision over the mass and I go to shell it out like I would my typical lipoma. And as soon as I touched the mass and as soon as I saw it, I'm like, alarm bells are going off. This is not just fat. Like, this is something more. And so I had to call Izzy's mom in the middle of surgery and say, hey, this is not what we thought it was. And we need to make some decisions, and we need to make them quickly because she's under anesthesia. Do we perform an incisional biopsy? Do we do a marginal excisional biopsy, knowing that we're going to have to go back in? Do we try to get clear margins, even though we have no idea what this mass is? I had a suspicion that it was probably a soft tissue sarcoma, but I didn't have a definitive answer. And, I could have aspirated it in the moment, but we know soft tissue sarcomas don't always shell out very well. And I don't have a great comfort with reading those in-house. And I wasn't going to have time to get a pathology review on it. So ultimately, thankfully, Izzy's mom, we have a long-term relationship, and we talked it through, and we decided to do an incisional biopsy because she was on board with doing an additional surgery. So the biopsy did come back as a soft tissue sarcoma. Thankfully, it was low grade, but it had gotten to the size where I didn't think I was going to be able to get clear margins with the location where it was. And so we ended up having to refer her to a surgeon for removal. They were able to get clear margins, and there's been no recurrence since. But, it's just my reminder of how important it is not to make those assumptions, because it is really awkward to make that phone call in the middle of surgery and say, hey, I was wrong. Now we have to make some decisions. And if this had been a high-grade tumor or something else, this could have gone very differently. And if we had known it was a soft tissue sarcoma when it was smaller, potentially we could have kept that surgery in-house. There are a lot of things that could have gone differently had we done diagnostics on that mass before we got into surgery. And because Izzy is such a lump factory, now we didn't have access to HT Vista when that particular lump was an issue, but she was my very first patient that we used the HT Vista on. And it is new technology that expands that spectrum of care for lumps and bumps, and it allows us to overcome a lot of the barriers to care. This is what the unit looks like. It's a small monitor, just sits on the bench top and has a little scanner head that goes with it. So when it works by heat diffusion imaging, and it works on the principle that healthy and malignant tissues have different thermal characteristics, and it is affected by the density of the tissue, how heat conducts through the tissue, the cellular metabolism, how vascular the tissue is. But in the scanner head, there's an LED heat source, a thermal sensor, and a camera. And so you clip the hair, and then it's a 40-second scan. The LED heat source heats up the tissue, and it looks at both normal and tissue next to the lump. And then it allows it to cool down, and it observes, a lot of characteristics of that. So this is a video where we're watching the tissue heat up and then cool down. And you can see here the tissue on the left of the screen is heating up much faster than the tissue on the right when it loops around again. So we see how much faster it heats up, and then it's going to start cooling down, and it's going to cool down much faster too. And so the HT Vista takes that and puts it into an algorithm that allows it to look at what the cancer risk score is. And these graphs are on the x-axis is time, on the y-axis is the heat, and it's comparing the behavior of certain types of masses to healthy tissue. So with lipomas, we can see that that tissue is going to heat up much faster than healthy skin. The mast cell tumors, it's going to heat up a little faster than healthy skin, but then it's cooling down much faster. And so the algorithm takes all of this information and it gives us a cancer risk score. And this is a busy slide, but the big thing to know here is, so our blues are our benign cases and lumps, and our reds are our malignant lumps. And when we look at the distribution of these cases, this is from the initial validation studies, which was over 1,100 masses. They looked at the probability of cancer in each mass. And so you can see when we look in the low cancer risk, which is classified as a 10% risk or lower, we have mostly blue lumps, so mostly our benign lumps. As we go further to the right and we go up on our cancer risk score, we are increasing the number of malignancies. And so we're seeing that higher cancer risk. There are still some benign lumps in there. So there are going to be some dogs with benign lumps that receive a high cancer risk score. But our goal here with this cancer risk score is we don't want to miss the malignancies. We would rather flag a benign lump as a possible malignancy than miss a malignancy and call it benign. And so that's why we have the 10% cutoff, because we are very confident in those being benign. And one of the great things now that HT Vista has been on the market for a while is that there are over 25,000 scans that have been performed in practice, and those results are consistent with the results of the validation studies. So we have a lot of evidence to support the reliability of this tool and how effective it can be as a screening tool. And when we look at the sensitivity and specificity data, it really does show us that it is a good screening tool because it has high sensitivity and high negative predictive value. So we remember that sensitivity is that ability to rule out a diagnosis, that if we're getting a negative test, negative test result, we can trust it. So we are not going to miss our positives. That negative predictive value means, is the negative a true negative? 98% negative predictive value, very high. Our sensitivity is also very high at 90%. Then the orange box here, you'll see diagnostic alerts. So the algorithm is continuing to evolve, and it can now flag lipomas and mast cell tumors. So at the very high end of cancer risk and at the very low end of cancer risk, there are enough differences in the behavior of those tissues, and there are enough cases with those diagnoses to know that sometimes the machine is able to tell that. And we can see here there's a high specificity, and we know that when we have a high specificity, we can trust the diagnosis. So we can trust the rule in. And the high positive predictive value with a lipoma and pretty high with the mast cell tumors. When it gives us that result, we can trust it. So again, this was based on the initial 1,100 cases on the validation studies, but it has panned out and continued to be consistent with the over 25,000 scans in the market now. And so this is what happens going back to those 20 dogs in the waiting room that have the lumps. If we scan all of those dogs, 60% of them or 12 of them are going to be able to leave the clinic with a low risk score. We're going to rule out cancer and say, your lump is benign. We're going to monitor it. Have a nice day. No need to worry. Of the remaining 8, we're going to recommend additional diagnostics. And by doing those additional diagnostics, we're going to find the 3 that have cancer. And you can see at both ends, we have that DX alert. At the high end, it's going to be the mast cell tumor. At the low end, it's going to be the lipoma. And that's that 90% specificity of giving us an idea of the type of cancer that we're dealing with. So it's just a reminder that, now we've got good confidence that we are not missing cancer. We have scanned all of these dogs. We have identified the ones with cancer. We are on our way to that diagnosis and getting them treatment. And so HT Vista, with that data, we can trust it. It can overcome our perception of assuming a lump is benign, but it has other advantages and it can overcome other barriers as well. It's non-invasive, so we're more likely that our patients are going to cooperate, and it's more likely that our clients are going to approve it because we can tell them there's no needles involved. We clip some hair, and then your pet just has to hold still for 40 seconds. May sound like a long time, but I promise they do really well with this. And I've had some patients where we have been able to do the HT Vista scan. This was a lump on the forelimb of a dog that we scanned with the HT Vista, and it came back as a high cancer risk. We recommended aspirate, and this dog was pretty high fear and anxiety, and he would not allow us to aspirate at the visit. And it was nice that we had the HT Vista to say to the client, hey, it's really important that we do this aspirate because there is a high risk of malignancy here. And so that motivated the clients to make sure that they did come back for a follow-up visit with gabapentin and trazodone on board. He actually had to come back for twice because the first visit, the drugs still weren't sufficient to get our aspirate. And we were eventually able to get a diagnosis for him and get him treatment, which we'll return to here a little bit later. It's also fast and efficient, so it overcomes that time pressure. These scans are performed entirely by my team members. It requires minimal prep, quick scan, and then the results are available quickly. So I can be working on my records while the team members are doing the scan, and then the results are available before the client leaves. So I'm not having to make follow-up phone calls to go over the results. I'm not having to review results later and delegate them to my team to call back. So it's much more efficient delivery of results. It's a patient side testing. And it's nice for clients because we know that when you start saying cancer, clients get scared. And so when we can tell them, we can give you a cancer risk score today before you leave and let you know if we need additional testing, that really can help to calm them down. If I can tell them this is low risk, we don't need to do anything but monitor at this time, they can leave with peace of mind. And these are pictures of my team performing a scan here just a couple weeks ago. This dog actually came back with a moderate cancer risk score. And we did an aspirate that was inconclusive. So our next step is to do a biopsy. She is scheduled for surgery in a couple of weeks. We're on our way to getting the diagnosis and determining if this is truly a malignancy or not. But it was great in the moment that we were able to get that started quickly and tell the client, before she left the building, we're worried this is cancer. We're doing the aspirate. We'll follow up with results. Unfortunately, it was inconclusive, but it gave us, more motivation for that client to get her into surgery for that biopsy because we had that cancer risk score. It's also affordable for our clients because we know that financial limitations are becoming a bigger and bigger concern. This graph is data from the PetSmart Charities and Gallup survey that was done earlier this year. And they found in the survey that 52% of pet owners have declined recommended vet care in the last year. And of those who declined care, 71% said they did so because of finances. It's a big problem that we're facing. But what this graph shows us is two big takeaways. The blue dots are those who could not afford the cost. And it's important to realize that this is not a problem just for our low-income clients. This is a problem for clients of all income levels. Even a third of our higher income bracket is saying we can't afford the cost of care. HT Vista scans are significantly cheaper than sending aspirates out to a clinical pathologist. And so if you have a client where maybe they were declining because of cost, we're able to offer them a lower cost screening tool so that we can make sure that we are getting some information about the mass and only doing that more expensive test when we have a high level of suspicion of malignancy. But the red dots are the clients who said, I don't think the care is worth the cost. They're not seeing the value in our recommendations. And to me, this is a big opportunity for us to better communicate the value of these cases. We know that when we have patients that we can diagnose these lumps when they are small, if this is a malignant lump, we are more likely to have a curative surgery. The surgery is going to be less expensive for the client. It's going to be less invasive for the pet. It's going to be easier on me as a surgeon. And so there are so many benefits to finding these masses and diagnosing them when they're small. But when the client comes in and the lump is only a centimeter or two, the client may not always feel the urgency to do the diagnostics. They may not feel that urgency until we are seeing the lump that is 5 or 6 centimeters, or it's growing rapidly, or now it's getting ulcerated and bothersome to the pet. But when we can, again, offer them a non-invasive tool to screen and say, is this something we need to work up further that is affordable to them? That puts a lot of value behind our recommendations, and it increases the value of our recommendations for further testing if we need to make them. And ultimately, HT Vista is currently the fastest, most efficient, and most cost-effective way to get that benign diagnosis and say, this lump has a low cancer risk score. We can call it benign. We're not guessing based on palpation alone. We are saying we have data to support that this is benign. You can feel comfortable monitoring this. We can scan it again next year to make sure nothing has changed. Have a nice day. Have fun with your pet. Because we know that we can't diagnose these by palpation. And we've already kind of mentioned a lot of the costs of these delayed diagnoses. It affects the pet's quality of life. It can cause more physical distress. We can see, as we said, a worse recovery from surgery, a more complex surgery. We can also sometimes miss our treatment window entirely. Has the mass gotten so large that we aren't able to treat it anymore? But if we had a mass where I told the client that, oh, I'm pretty sure that's benign, that's nothing to worry about, we don't need to do anything, we'll just monitor it. And I didn't talk to them about diagnostics, and we didn't do an aspirate. And then next year, the mass has tripled in size, and now we're diagnosing it as cancer. That puts my reputation at risk. That puts the client's trust in me at risk. And we may lose a client over that. Additionally, the clinic is going to lose the intervention that we could get, the income that we could see from working with the clients to do further diagnostics, staging those lumps, taking them to surgery. I had a dog that came in a couple of years ago for a small lump on his toe. And we did an aspirate, but it was inconclusive. There was concern that this could be a malignancy, and I recommended biopsying the lump. It was small enough at the time. I told the client, like, we could start with just a marginal excision to do the biopsy. There may be a follow-up surgery needed if it is a malignancy, but then we'll know what it is. We'll have it removed. The client never scheduled the surgery. And 2 years later, he returned, and now the dog had a mass the size of an orange attached to his toe, and it was necrotic and ulcerated and bleeding. And it was a mess in the client's house, and it was painful for the dog. It was infected. And we ended up having to do a much more invasive surgery. We had to actually amputate 2 toes to be able to remove the mass, just to be able to have enough skin to close. And ultimately, it came back as a soft tissue sarcoma with dirty margins. And so we weren't even able to be curative with that surgery. We had a lot of complications with healing. And, the dog had a lot of issues after the surgery. And it was hard for us as a vet team to think, hey, like, could we have communicated differently? Could I have said something differently to this client 2 years ago when this was small to really convey why we should have done surgery then? And, we can what if for, hours, but we can see that these cases can have an emotional impact on us as veterinarians, as well as our pet owners, when we miss these diagnoses or when we miss the opportunity to make these diagnoses. And so having this tool that allows us to screen these cases and have more confidence in our recommendations is really, really fantastic. It also is a revenue generating opportunity for us in practice. So if we think about the 20 dogs in the waiting room and our standard 38% aspirates, we are getting the revenue from those aspirates on about 7 dogs, and maybe we catch one of the dogs with cancer. We do that histopathology, and we have some income from that workup, but we have 2 dogs walking around with cancer that we haven't identified. And so we are going to have delayed diagnoses with those dogs. But if we've scanned all 20 of those dogs, we have the revenue from the scan themselves. We aspirate based on knowing what the cancer risk score is. We aspirate with the evidence that, hey, this is a moderate to high cancer risk. We need more information. We identify the 3 malignancies and take them to surgery. We have higher income, but we also have confidence that we aren't missing something. We have found those dogs with cancer. We have gotten them to surgery. We have treated them. And ultimately, we can feel better about the fact that we are doing the best we can for our patients, and we get to benefit our business as well. So going back to our fractious friend from earlier, when we did finally when we got the scan, it came back, as I said, with the high cancer risk score. So this is what a report looks like. So you can see it gives you a percentage of the cancer risk and then classifies it as low, medium, or high. It gives you copies of the thermal images and the optic images. So it's something you can give this as a printout to the client. But with that high cancer risk, we encouraged the client to come back for the aspirate, and they were very motivated to do that. And ultimately, we did diagnose this dog as having a mast cell tumor. Now, because of the location of this mass, because it was high up on the leg, the size of it, I was concerned about my ability as a surgeon to be able to get clear margins. And so I recommended that we I gave the clients the option of going to a board certified surgeon, and they did. The surgeon was able to get clear margins, and it was a low grade tumor. So this was a curative surgery. At the time that we aspirated this dog, the HT Vista didn't have the subclassifiers available yet. Potentially, this may have been a case that we may not have needed to aspirate at all, because if we had gotten the mast cell tumor subclassifier, we potentially could have had the diagnosis with the scan alone, and that would have been even better for this patient's stress level. But as the technology continues to evolve, we are getting better and better data and more accurate and more reliable results. I've been using it now for over a year, and it is so fantastic to know that we can take these lumps that before, I think this dog probably would have gone undiagnosed if we had attempted an aspirate and it didn't work. I don't think those clients would have come back. But because I could say to them, hey, we did the scan, we are worried about cancer, we really need to do more testing, we were able to get them the diagnosis, get them the surgery, and get this dog a cure. And when we think about talking to clients about the HT Vista, typically the way that I approach this conversation is, I palpate the masses, I measure them, and I tell the client, I can't tell you what this is just by feeling it. But I can do a quick scan of the mass that is going to tell me what the risk of cancer is. If this comes back as a low risk, then we are able to know that we just need to monitor. It's not going to give us a definitive diagnosis of what type of mass it is in many cases, but we can be confident that it's not something that we need to worry about. If it comes back with a moderate to high risk score, then we are going to recommend further testing, which we can do today because we're going to know before you leave what that score is. The next step is going to be a fine needle aspirate, and then I'll describe to them what that procedure entails. And, I stress to them the fact that it is non-invasive and that we have the results quickly. And I have pretty high compliance with these scans because I present it as a way of, this is going to give you peace of mind. And I can't tell you what the mass is, but with this tool, I can tell you if this mass is benign or not. And so it really is changing the way that I approach lumps in practice. It has expanded the number of patients that I'm able to test and get a diagnosis for. And it really is a powerful tool that is allowing us to improve access to care for our patients with lumps and bumps. And so with that, I will take any questions.
Wonderful. Thank you so much, Kate. What a great presentation. I loved it. And it looks like we had some Q&A going during the presentation and everything, some really great back and forth, but hopefully this is a good opportunity to dive into a little more detail. You ready?
Yeah, let's go.
Wonderful, wonderful. So some people may have kind of seen this in the chat, but just to go into a little bit more detail, first question was about little Izzy, and kind of what the follow-up was with her. It sounds like she had clean margins. Was it just monitoring after that?
Yeah, so since it was a low-grade soft tissue sarcoma, and with the surgical specialist, they were able to get clear margins. We've just monitored since then. She didn't need to go through any additional treatment. We're over a year out now. No recurrence so far. She's had, several other cysts and other dermal nodules, but that's why she became my very first HT Vista patient. So she's been my poster child.
Absolutely. Absolutely. Yeah. I think, we've all had those like gut dropping moments where like, oh no, this isn't what I thought it was. But what a good outcome to have gotten complete margins and done all of that. And then, now to have this technology to continue to monitor all of her little lumps and bumps she likes to grow.
Yeah, and actually when I asked her owner if I could use her case as an example for the presentation, she was like ready to have Izzy like groomed and like live with me. And I'm like, "Oh no, I just need a picture of her." I'm like,
Oh
"I love
no,
Izzy,
we want the real deal here. I would love to see Izzy. Well, tell our owner that we missed her. We would have loved to have her, but yes, it probably would have created a little bit of chaos during the presentation. Oh, well, wonderful. I'm glad to hear that she's doing well. This one, I know you went into it a little bit, but there's probably a lot to say here. The question was, without having this technology, what would you do with a patient who presents with multiple lumps at one time, greater than 5? That is always a challenge because it can be a lot financially to aspirate all of them. It can be a lot on the patient. That's a lot of pokes. And sometimes it can feel like there's a little pressure to sort of prioritize, which you kind of did a great job illustrating some of the pitfalls we can run into with that.
Yeah. So I think there's a couple ways to, you can approach it. Like, yes, ideal, like textbook approach would be aspirate every single one of them. But especially if you're going by, sending them all to a pathologist, like that gets really expensive really quickly. So, if I have an owner who does want to aspirate them all, a lot of times what I'll do is I'll look at them in house, because some of them, like, you look at the slide, you're like, okay, this is grossly fatty. We stain the slide, nothing stuck to it. I'm comfortable calling that a lipoma. We move on. So, I think if we do aspirate them all, I think we decide which ones actually need to be sent for further review. Or we go through and we talk to owners about, pros and cons, and say like, okay, based on my clinical suspicion, these are the lumps that are most concerning. I just had a dog last week that came in and had like a ton of the soft, freely movable subcutaneous nodules. And I said, I can't tell you definitively, but these are, I would lean towards these being benign. And on further talking to them, they, they said like they had been there for ages. This was a new patient to us, but they said like they've been there for years, like they aren't changing. And I said like, I can't tell you definitively, we could be wrong, but if you want to just continue to monitor them, because that's what you've been doing, you can. But I said, but you have 2 dermal nodules that are a little red and irritated, and I'm like, those just worry me a little more. And so they did approve aspirating both of those. We didn't do a scan on them because one was right along the mammary chain. And I couldn't tell if it was an actual mammary nodule or something else. But the mammary chain is one area that you can't scan because the tissue is different. So since I couldn't scan that one, and the way, since we use the Imagist and we can send samples from 2 sites for the same price, I was like, well, we'll just, you already have to pay for one. So we just aspirated them. They both came back mast cell tumors. So in that case, like, clinical suspicion was correct. And so we're working on doing staging for that dog and sending it, getting it ready for surgery. But yeah, so I think it's kind of you have that conversation with the owner and you say, here are the pros and cons, here are the risks of not aspirating, and go from there.
Sure. Recognizing that, there is nuance to it. There are challenges inherent to that type of a situation, and doing the best you can with it. But it is a good argument for this type of technology to at least narrow things down. I love that answer. I could relate to everything that you said, especially, those mast cell tumors. I had a mast cell tumor surprise me. I think it was last week. Where I poked a mass and some fluid came out, and I went, oh, it looks, it's probably cystic, let's go ahead and stain it. We'll just see what we get. Maybe it's, maybe it wasn't super clear fluid. So I was like, maybe it's a little infected, abscess. Nope. It was a mast cell tumor. So yeah, always good to check them, especially if you have any degree of clinical suspicion. Let's see. Okay, this one says mixed lump. Some have a smooth cyst-like, one that's not smooth, ulcerative, pigmented, now larger in size in the last year. What do you do? I think the question is, if you have, it sounds kind of along the lines of what you just described there. That you have some that are smooth and have these encouraging characteristics that look benign, and then one that's not. And so I don't know if you want to expand on that at all. It sounds similar to the situation you described there.
Yeah. I mean, I think, like, for me, like, if they're, and especially if they're changing character over time, like, even if we scanned it last year and it gave us a low risk score, like, if, ideally we would scan it like yearly just to make sure that we're not seeing a change. But especially if characteristics of it are changing, then I would absolutely, rescan.
Absolutely. Yeah, that's one of those red flags for me as well, to say if there's a change, then, monitoring really goes way down on the list of options I'm comfortable with.
Right.
Absolutely. I feel like that gave us a lot of information. Let me just do a quick check here. This one, are there other areas you can't scan? I saw something that said, before, do we need to be careful around the eyes? You mentioned the mammary chain.
Yeah, you can't scan the eye. So, like, if you have a mass near the eye and you can get the scanner on the head, like, in an orientation where it's not scanning over the globe of the eye, you're good. But, like, you wouldn't be able to do an eyelid tumor, or, like, if, depending on the orientation of the mass, like, if you can't do it in a way that you can, you can't put the scanner head over the eye.
At all, even if you're not, like, even if that's not your goal, you can't have it anywhere over the eye at all, is what you're saying.
Right.
Got
it. And then it doesn't do lymph nodes.
Okay.
And like, the foot pads aren't really an area we can do.
Okay. And you said it's because there's differences in the tissue in these different areas?
So because it's comparing, like, normal tissue to the lump tissue and the heat diffusion, like, you think, like, the mammary tissue is a lot different characteristic, the lymph tissue is a lot different. So it just doesn't have, like, this, it's not going to be accurate because the scanner doesn't, like, its normal baseline isn't there.
Gotcha. So, like, of course, the lymph node is going to scan differently from the tissue around it. So it doesn't really give you the information that you're looking for. Right. That makes sense. Got it. All right. Let me take another look here. Got some questions.
I did see a few questions on, like, size wise.
Yeah.
And yeah, like, I will pretty much scan anything over 5 millimeter diameter. And if they're really big masses, then ideally you would like scan it in a couple spots, just to make sure you're getting a representative sample.
Okay. Absolutely. And then it's how small, like, I think this goes along, you said 5 millimeters is your cutoff.
That's the guide I use. Like basically if I feel like I can poke it, then I'll, I should be able to scan it. And I usually don't feel like I get very good samples for anything less than like 5 millimeters. So that's the cutoff that I use personally. Cause I don't think I can really get a good aspirate on anything smaller than that.
Yeah, that makes sense. Going back to location real quick, I'm thinking of a patient actually I saw just yesterday, and got a little lump on his tail. It looks very cystic, hasn't changed or anything. So, we're keeping an eye on it. But is the tail a region that we can scan?
Yeah, well, at least like tail base for sure.
Okay.
Like Izzy actually, so one of the very first masses we scanned on her, was a tail base that we swore was cystic. And it flagged like a high risk, and we're like, seriously? And of course my team was kind of skeptical about the technology to begin with, and then we thought for sure these were all benign lumps. And then like the very first lump we scan, it flags, and I'm like, oh, great. So we aspirated it, and it was an inconclusive aspirate. So we ended up taking her to surgery, and it ended up being a hemangioma. So it was benign, but it was not like a typical cyst. So, so it was like, it definitely flagged it as, something that could be potentially concerning. So, but yeah, that one was like right at the top of the tail.
Gotcha. And so really kind of sticking closer to the body and not getting way out there on the tail in a lot of these cases. But that could be really helpful even in that tail base area, because it's not a comfortable area to poke if we have another option.
Right.
Yeah, absolutely.
Yeah, and I think as long as you have a decent amount of normal skin next to it that you can compare to, you should be able to scan it. So we've definitely done several on the tail. I haven't gone out towards the tail tip, but definitely at probably that proximal third of the tail, we've scanned a few.
Okay.
Like we had one that was a perianal gland adenoma, which I did not know until recently that they have perianal glands on their tails, because they're hepatoid glands.
Oh.
So yes, I have removed 2 hepatoid gland tumors this year from dogs' tails.
Really interesting.
And I did not know they had those glands there until this year.
My goodness.
And both of them we scanned, and they came back as like moderate risk, and so we aspirated and then proceeded to surgery.
Interesting. Yeah, I mean, learning a lot of things today. Yeah, those anal glands, they're there for nothing but causing problems, I swear. Now we have perianal glands, my goodness. I think we got through a lot of these. There, some of these you've already answered. This one, learning that FNAs can cause certain types of cancers to spread. I don't know if we're talking about seeding here or like making a sarcoma angry with our aspirate. But would you consider recommending to a client that they go straight to surgery if there's a high risk score with an HT Vista, or do you think it's more important to do some diagnostics ahead of time, know what you're dealing with in terms of like an FNA or a biopsy or something like that?
Yeah, so I mean, I guess I don't worry too much about the FNA causing spread, especially for a dermal or a sub-Q nodule, because I'm not worried about like seeding the like tract like I would be with like if I were poking a bladder tumor or something like that.
Sure.
I would certainly defer to an oncologist or a surgeon if they had a different opinion on that. But I mean, I would say, I think that in general, I think knowing what type of tumor we're going in on is is important for surgical planning. Now, if it flagged it as a mast cell tumor, I think I would feel comfortable going in without the aspirate, because it's not like they can usually tell me they can't tell me the grade of the tumor from an aspirate anyways. So if I have if I have, hey, this is a mast cell tumor, then we talk to the owners about like what pre-op workup we want to do, and we can proceed with surgery. Because I know my guidelines for margins already. But if we're not sure, then I would say like ideally I would want to do the aspirate. Now, if it's like a small tumor and it's on the flank and it's like, hey, I've got tons of skin to work with and I can just take wide margins to be safe. It's talking pros and cons with the owners. And if it's a case where maybe finances are kind of tight and saving the $150 on the aspirate is going to allow them to send the histopath off, then yeah, if I feel like, as long as the owners understand, like if I'm going in here blind, like there's a chance we might not get it all, there's a chance we could have healing complications because we don't know what we're dealing with. It could be a mast cell tumor and we don't know. So I would say like, ideally I still try to get them to aspirate, but it wouldn't be completely out of the realm that I would go to surgery without that.
Yeah, I think that makes a lot of sense. And you're really kind of leaning into that spectrum of care there and having those conversations with the owner and finding out what's going to work best in that individual situation. Well, wonderful. Well, I know we're kind of at time here. So let me pause there for a second. Were there any particular questions you saw come through the chat where you wanted to talk about those a little more, or any final thoughts you want to share with us?
I think we've got all of the big ones.
I think so.
So, yeah.
Yeah, and there was some. And Asher, thank you so much for fielding some of those technical questions and availability and this kind of stuff. And yeah, thank you to everyone. I'm glad we were able to get through all the questions. I guess I'll go ahead and wrap it up so that we're sensitive to everybody's time. As a reminder, if you're registered on Vetfolio and you're attending live, no further action will be needed to obtain your CE credit. Remember, our YouTube audience, if you registered through YouTube, be sure to fill out the JOT form linked in the description. You'll see your CE certificate in your Vetfolio learner profile within 24 hours. This session will be available through Vetfolio in the coming days. Thank you all for joining us. Big thank you to Dr. Boatwright for a fantastic presentation, fantastic discussion.